Good afternoon, everybody. I'm Florent Chevalier from Hospital of Saint-Quentin. Saint-Quentin in the north of France, between Lille and Paris. So is investment procedure useful? This is the case of Mrs. D, a 66-year-old woman with hypertension, diabetes. She had angina CCS2 and ischemia in the LAD territory. She was addressed at our center in Saint-Quentin for angio. I let you see the right coronary with the occluded LAD. So when we look after that, we look at the scores. The JCTO score, there is 1 point with calcification, 1 point with the bend. And when we look at the progress CTO score, there is 1 point with tortuosity. 1 year ago, it was my first attempt. I started with my plan of integral wiring because there was no ambiguity, there was no poor distal quality, so it's okay. I started with my extra backup and my Mamba microcatheter. I started with a Fielder XT, but I rapidly stopped because it was very calcified. I tried with Gladius and with a Gaia tree, but I always was very far from the lumen. And I could not re-entry despite many attempts. I injected a lot of contrast and I needed to stop. 2 hours later, after 400 cc of contrast, no significant progression, I took a deep breath in and said, okay, I need help, a second attempt with a proctor. I called Alexandre. Again. Unfortunately, 2 weeks later, Mrs. D is admitted to emergency for acute kidney injury. 3 weeks later, she was discharged at home, hopefully with a correct renal function. We report the intervention, but 5 months later, the second attempt with Alexandre, we planned an integrate strategy again. We started with the Mamba Flex microcatheter and Gaia tree. But as the first time, we always were outside the lumen, despite the Gladius, the Hornet 14. We tried Gaia tree. Finally, with the Gladius, we were close to the lumen, so we advanced the Stingray balloon. We tried to re-entry, but we could not. So we changed our strategy. We wanted to switch for a retrograde approach. We injected selectively the collaterals, but we could not use them in the PDA now. And we lost the distality of the vessel. So this is the last picture. With the Gladius, we put the Gladius in the second diagonal, and we decided to invest. And we did an angioplasty with a 2.5 millimeter balloon in the mid LED and the prox LED, and decided to go back 3 months later. And 3 months later, the LED was permeable. We started with Corsair XS Pro, and with a sillon wire, I advanced the sillon very gently, and he found the second diagonal where the gladius was before the investment. I advanced my microcatheter, and after that I found finally the distal LED. In 1 minute. So we were very happy. We decided to do a NIVUS. We advanced a NIVUS catheter. It was an ACIST HD 60 IVUS catheter, which has a good profile. And this is the first run, the pre-stent run. It's a little bit long, but we are in the distal LED. We can see that the LED is very, very calcified. And at 7, we will see the second diagonal where the gladius was just before the investment at 7 o'clock. Just here it appears. Yes, and we can see that we were more proximally in we were the IVUS catheter, and our wire was extra black because the true lumen is at the right side of the picture at 5. So, and after that, more proximally, we were again in the true lumen. I show you again just a picture with the LED. Here we were in the distal LED, which is a very calcified artery. And here I show you again the picture with the IVUS catheter, which is extra plaque, and the true lumen in the right side of the picture, and the picture of the proximal LED. After predilatation, we implanted 2 DES, Firehawk Liberty, which is a bioresorbable polymer sirolimus eluting stent with a high radial force, and we chose this stent because we needed a stent with a strong radial force and a good crossing profile. In this very calcified LED, we implanted 2 DES. I show you the result. And the picture, just the picture of the IVUS post-stent. I controlled Mrs. D 4 months later. Well, Mrs. D is fine. And if you answer me, is investment procedure useful? I can now answer, yes, it is. Thank you.
Yeah, thanks, Florian. Thanks for the picture. I remember it, don't worry. I don't know if there is any question about the investment procedure.
Absolutely. How often does this investment pay out in the end? How high is the probability after such an investment attempt that it really stays open until follow-up? How often does it work?
I think it's, in my experience, it's around 60%. Then after, but you have to balloon the proximal cap. So you have to be sure that your distal wire is in true lumen, and wiring the proximal cap, just modify the cap and create some connection between true lumen, subintimal space, and then true lumen, create some flow. And then the question is when I have to come back for my second attempt. So we discussed with us, and we said the best maybe is between 2 or 3 months. And so
Did you have flow after your balloon dilatation as an investment? Did you have flow at the end of this second procedure?
Yes, we had flow from the proximal LED to the distal diagonal.
I see.
I think,
not to the
I think
LED.
there's a lot to say
Not
about
to the
subintimal plaque modification, star and effort stenting. It deserves a full topic and a full presentation. It's a lot of data that's still to come. But I think these are a great question, and we don't have a lot of answers to it, but there's still, and for the sake of time, I think right now, it's time for break. Maybe one question.
There is one question with Lorenzo.
Yeah, so I think data from Progress CTO showed that the optimal timing for bring the patient back to the cath lab is after 60 days. The patency is higher, and also data from Bill's group in UW. So they brought back systematically. Well, they tried to bring back most patients that they had a failure. They had a success rate over 90%, and the 10% that they failed, they brought back, and the success rate after investment procedure in this cohort of very tough CTOs was 85 or 88%, which is very high for failed cases by Bill. So I think investment really pays off, and it's the way to go as long as you know that you are in the vessel architecture. You cannot, of course, balloon in the middle of nowhere if you're not sure where your wire is.